Not a problem, not a problem. I'm happy to be here. All right, I'm happy to be here. We'll just wait on a few more persons and see who is gonna join us. Hope we have a good night tonight again. The last live was very, very good. Uh-oh, it's everybody in the house. Oh, yeah, just make sure you're hydrating yourself, getting your vitamins in, especially your vitamin C. Get those in and try to prevent, you know, anything else from happening. If you need to get your swabs done, I don't even know if people are getting swabs done nowadays, but just still try to protect each other, even though probably everybody is infected. All right. The most important thing is making sure that you're hydrating. Hi, everyone. Welcome, welcome, welcome. Can go ahead and, yeah, tap up the live. If you're new here, can you just put a heart in the comment section? If this is your first time on my live, can you put a heart in the comment section? That would be nice. All right, so I can know who is here. And even if you're passing through, that would be appreciated as well. You just saying hi. All right. Okay. So are you a nurse, Akon Marie? Pediatric. Oh. Pediatric. Rez, welcome. Let's see who else is here. Let's see who is on YT. And remember to go ahead and follow me on YT as well. Subscribe to the page on YT. The full length of the live streams are posted over there. So you can always access them at your own convenience, at your own time. As well. Okay. All right, we'll try to get the chat up to, or the live up a little bit more to probably like 1,500. Okay, so you just go ahead. So the name I put here, all right, just go ahead. You can put the little @ sign as well. Go into YouTube and just type it in. So it's the same name. The handle is the same name as my name here on TikTok. So just go on to there and just type it in and you'll see the little icon. The icon is the same as the one on TikTok here. So at least you won't miss it. Faith, thank you for tuning in and for liking up the live. Remember to go ahead and share as well. And then the heart that is above, well, close beside, the icon, my name, just go ahead and click on it to do your daily heart me so you can actually score your points. All right. If you're making content, it doesn't make sense you have the heart meals and you're saving them up or you're distributing them and you're not doing your, collecting them, claiming your points. So that's how you get your, your live or your page being recognized as well. All right. So remember to do that. All right. So I guess everybody here for the first time has been here before, right? Uh-oh. Lord. Let me get this back on. Okay. I'm gonna have to keep on touching the... Okay, all right. We can always start 7:05 on my side. All right, so the first question, so as usual, think safety first, think safety for the patient, for yourself. Answers are gonna be A, B, C, D. Choose an answer, save the patient, and that's what we're gonna be doing tonight. All right, and we'll study together, learn together, most importantly. All right, so let's get cracking. A client with schizophrenia stops taking meds due to sedation. What is the best nurse's response? A, tell them medications are mandatory. B, increase the dose. C, discharge the patient for non-compliance. Or D, explore side effects, collaborate with the prescriber to adjust medication, and discuss adherence strategies. Definitely D. All right. And the answer, the rationale there is address the side effects and work with the prescriber to find tolerable regime and adherence to strategies. All right. And as I go along, I'll ask you additional questions as well. So just bear in mind that, you know, I might ask 1 or 2 questions about schizophrenia or something like that for you. All right. So let's go on to B. All right, a patient with acute panic attack arrives to the emergency department. Should I try to get this up a little bit bigger? Can I? No. What is a priority nursing intervention? All right, A, encourage deep breathing, remain calm, stay with the patient, provide simple instructions. B, insist they think positively. C, leave the patient alone to recover. D, give long, detailed explanation of anxiety. All right, A, encourage deep breathing, remain calm, stay with the patient, and provide simple instructions. Definitely always go ahead and talk through what is happening with your patient. All right. So stay with the patient, provide simple grounding and breathing techniques, avoid overwhelming information. All right, never leave the patient alone to recover. All right, because sometimes you don't know what they're thinking. Might sound like panic attack and that's it, but you know, sometimes they might be having other things going on. All right. Give long detailed explanation of anxieties out of it and insist they think positively. Well, you can always talk about positivity, but you don't have to, you know, encourage them at that time, like, you know, so much. 3, a teenager expresses fear about coming out to family. What is the best initial nursing action? A, encourage immediate disclosure to all family members. B, provide support, assess safety, and other resources. C, insist they keep it secret forever. Or D, inform the teen their feelings are temporary. Let's see, B. Okay, provide support, assess safety. Okay, and offer resources. Nice. So you want to assess safety and provide support and resources. Disclosure decision should be patient-led and safety-focused. All right. Thank you, T, for joining in. All right. A client with anorexia has a low potassium of 2.8 milliequivalent per liters. What is a priority nursing action? A, provide unrestricted meals. B, ignore potassium will self-correct. C, notify the provider and implement cardiac monitoring. Plan safe refeeding protocols. Or D, encourage exercise to increase appetite. Am I the one that is seen? Is it dull or? Okay, C, notify the provider and implement cardiac monitoring. Plan safe refeeding protocols, definitely. And we know the risk when you have low potassium or any abnormalities with your potassium. What are these patients at risk for? What is this patient at risk for? Arrhythmias. Okay. Yes, definitely. So you definitely want to make sure you get your EKGs for these patients, get them on the cardiac monitor, you know, get IVs in and just monitor them. All right. What are some medications, if you're thinking about arrhythmias, what are some medications you're thinking they could possibly, or just give me a few anti-arrhythmic medications that you know. What are some examples of some okay, so potassium level needs to be between 3.5 and 4.5. Okay, digoxin. Thank you, Diana, for the follow. Do we know any other? Your anti-arrhythmias. Medication. I'm on the live. No, furosemide is a loop diuretic. That's the calcium gluconate. Well, that can help, you know, with the muscles. All right. But you also have like your lidocaine, your propranolol. Procainamide. All right. So you have your beta blockers such as your metoprolol. Yes, your metoprolol, your atenolol, propranolol. You also have amiodarone. Those are some form of verapamil. All right. Calcium channel blockers. Definitely. All right. So always think about those. All right. So let me get this back up here. All right. So for this patient, the patient is has low potassium 2.8. All right. So you definitely want to go ahead and notify the provider because hypokalemia is dangerous. All right. So monitor the cardiac status. Ensure safe electrolyte repletion during refeeding. All right. A patient with dementia becomes physically aggressive at sundowning. What is the best strategy here? A, use physical restraints to control behavior. B, de-escalate verbally. Provide calm environment. Reorient, provide routine and lighting to minimize sundowning. C, sedate immediately. Or D, allow aggression to continue. Okay, so B, de-escalate verbally. Am I touching on the screen there? I'm not getting used to this thing yet at all. All right, so definitely non-pharmacologic de-escalation first. Restraints or sedation are last resort due to risk. All right, if you have a patient that is in restraints, how often do you go about with renewing, getting those renewed, their orders renewed? For an adult. So Benny says every 2 hours. For an adult. So for the adults, you do the order you renew it every 2 hours, or you do the reassessment every 4 hours, every 2 hours for your adolescents, and then every hour for your children, like, you know, anybody that is less than 9 years old. And you try to always get those orders done, like, you know, within the 24 hours. All right. So the reassessment is like every 4 hours for adults, every 2 hours for your adolescents. So anyone between, I think, 9 and 17 thereabouts is every 2 hours, and then anyone under 9 is every hour. All right. And then you try to get the orders done in the chart within the 24 hours. All right. And what are some things, if you have a patient in restraint, what are some things you'll be checking for during your reassessment? During your 4 hour, 2 hour, 1 hour period, what are you checking for during those times? You're looking for circulation, skin integrity, making sure that they're comfortable, you know, check their mental status. Skin assessment, definitely. All right, definitely. All right. So skin assessment, yeah. All right. A new mother has postpartum blues versus postpartum depression. Which findings suggest depression? A, tearfulness lasting 1 to 2 days. B, transient insomnia. C, mild mood swings that resolve. Or D, persistent hopelessness, suicidal ideation, difficulty bonding lasting greater than 2 weeks. And welcome on YT there. D. Okay, nice. Definitely. How do you determine, how do you know the difference between what is the giveaway there? Well, between the postpartum blues and the depression. Doesn't last longer. Definitely more symptoms negative. After 2 weeks is depression. Definitely. All right. So anything after 2 weeks is depression. So severe mood disturbance and suicidal ideation, yeah, those suggest your postpartum depression requiring evaluation. All right. So for your postpartum blues, as we say, it's temporary and it usually resolves within the first few days. All right, like probably like 1 to 2 weeks thereabouts. All right, some of the times they'll have the mood swings, the crying, irritability. Sometimes they're just feeling overwhelmed. They can't concentrate well. They have loss of appetite. All right. And anytime it's longer, then definitely you're thinking about a depression when it is associated with any suicidal, you know, ideation. All right, so that is what makes it different. All right. If the same persists for 2 weeks, definitely. Okay. A patient with borderline personality disorder idealizes, then devalues staff. What is the best nursing approach? A, maintain consistent boundaries, clear communication, and therapeutic limit setting. B, avoid setting limits to prevent conflict. C, ignore behaviors. And D, share personal problems to build a rapport. Hi, Carousel. Dini says A. Okay. So I'm trying to go until not 8 o'clock, 8:30 the latest. All right, trying to go until 8:30 the latest. So maintain consistent boundaries, clear communication, and therapeutic limit setting. All right. Definitely. All right. A client reports hearing voices telling them to harm self or harm others. What is the best immediate action? A, encourage them to follow instruction of voices. B, tell them the voices are not real and ignore report. C, ask for details, ensure safety of patient and others, notify the team for emergent intervention. Or D, document and wait until morning. C, definitely. Always go ahead and assess. All right, start off with assessing. Ask for details. Ensure safety of patient and others. And notify. All right. Notify the necessary persons. So auditory command hallucinations to harm indicate high risk. Assess specifics and take immediate safety actions. All right. A culturally diverse patient refuses blood transfusion for religious reasons. The orange should A, discharge the patient, B, force transfusion to save life regardless, C, mock beliefs of to encourage compliance, and D, respect refusal, document and collaborate on alternative treatments. Okay, so D, respect refusal, document and collaborate on alternative treatments. Nice. What are some alternate medications, or what is some alternate what you call it now? Crystallides, colloids you could actually use for a patient who is not wanting any form of blood products. What can we use as replacement? So they don't want blood products and they need to get iron, you put in alfalfa. Okay. All right. Iron. All right, nice. All right, so you can always do your iron supplements, ESAs, which is the erythropoiesis stimulating agents. Can do vitamin therapy like your B12, folic acid, those things. All right, to help with stimulating, like, blood production. And then if you'll always think about your crystallides, like your IV fluids. Venifer, okay, haven't heard that in a long time. Yeah. But you can use a regular IV crystallides, such as your normal saline, your lactated ringers as well. And if you're thinking about like colloids, like your albumin, that is something that is frequently used. There is also dextran and no, it's not dextran. What was that one? Yeah, those are a few of them. All right, that they can use as alternate drugs. Let's just say our blood products, or it's not really blood products, but things to help with getting their blood pressure or their blood products elevated. All right, so depending on what is going on, if they're having blood loss, things like those. All right. So we said that this answer would be D. Definitely respect the patient autonomy and beliefs, document informed refusal, and seek alternative care while discussing risk. All right. The next one is a client with PTSD has nightmares and hypervigilance. Evidence-based nursing interventions include A, prescribe benzodiazepines only, B, suggest ignoring memories, C, exposure therapy referral, trauma-informed care and coordination with mental health services, B, encourage avoidance of all reminders. All right, so C, okay. Nice, definitely. All right, so C. All right, so trauma-informed care, CBT, or exposure-based therapies, and you get psychiatry to manage them. Can also do benzos, but that is never the first line for treatment. All right, what are some examples of some benzos that we can use for your psych patient, or in general? What are some examples of your benzos? Clonazepam, okay, midazolam. Okay. And how do we reverse if we have a patient that has overdosed on a benzo? What's the reversal agent for your benzos? Flumazenil. Okay, nice. All right, so you have like your Valium, Ativan, lorazepam, Xanax. You also have your clonazepam. I see somebody said that as well. All right, as some of your benzos there. All right. Which one of the benzos do they normally use for a patient that is going through alcohol withdrawal? If you have a patient going through alcohol withdrawal, which benzo you think they'll use, or which one is most often used for your, okay. I see diazepam there. And also your Librium, all right. Your Librium is one that is most commonly used for your alcohol withdrawal. Yes. All right. A post-op patient with a PCA pump reports inadequate pain control. All right, what is the initial action here? A, increase basal infusion without order. B, assess pain, sedation, pump settings, and communicate with provider for changes. C, tell the patient to wait longer. D, remove the PCA pump. Okay, B, assess. Assess pain, sedation, pump settings, and communicate with provider for changes. All right. Why is this one so close to it? All right, definitely. All right, so what are some of the different ways you can actually assess your patient's pain? What are different scales you can use to check your patient's pain? They have different pain scale out there. What are some of them you can use? What are some of the names? All right, you have the face scale, okay. Yes, so you have your face scale, you have your flat FLACC scale as well. You have your regular, like, you know, the numeric, the 0 to 10 scale that you can use as well. All right. And we said the Wong Baker, the face scale. All right. So just read on those and know when you use each scale. All right, because each of them can be used for different, like, you know, if a patient is intubated, you need to know which pain scale to use. If it's a pediatric, you need to know which one to use, things like that. All right. So a lot of times the Wong Baker, the face scale is the one that they use for children. For persons like adults who are communicating, you know, they're with it. You can always use your 0 to 10 pain scale. The FLAC scale can also be used for your infants, all right? But a lot of times the nonverbal patients, all right, you can use that one with, because it looks at their face, their legs, their cry, and all right? So read on those so you can be familiar with who you'll use each scale for, all right? What is the best technique when assisting a weak patient to ambulate? A, stand behind and hold gait belt at all times. Use appropriate assist level. B, hold under arms only. C, let patient walk independently immediately. D, support by grabbing clothing. So what is the best technique when assisting a weak patient to ambulate? Stand behind and hold gait belt at all times. Use appropriate assist level. All right. And that's the answer. So use gait belt and appropriate body mechanics to protect patient and nurse. All right. A child with nasal congestion. How do you go about with, you know, giving them safe decongestion use? A, give topical decongestion for several days to relieve obstruction. B, aspirin for decongestion. C, use saline, drops, and suction per age. Avoid prolonged topical decongestions due to rebound. Or D, give adult decongestant dose. So if you have a child who is congested, what is the best education you can give there based on these answers? Okay, so use saline nasal drops and suction per age. Avoid prolonged topical decongestions due to rebound. All right, so the answer there is your C, saline and suction are safe. All right, topical decongestion risk, rebound rhinitis if overused. When you have your patients that you're suctioning for your, who have your, even if you're doing just regular, endotracheal suctioning, when you're doing your endotracheal suctioning as well, you can always put a little bit of a normal saline there to help with loosening up that secretion. All right, when you're suctioning. All right. The nurse is providing oral care to an unconscious patient. Which action is correct? A, place the patient in supine position and use only water. B, force toothbrushing vigorously. C, skip oral care to prevent aspiration. D, position in lateral or recovery position to prevent aspiration and use suction as needed. So the nurse is providing oral care to an unconscious patient. Which action is correct? Place the patient in a supine position, force a toothbrush vigorously, skip oral care to prevent aspiration, or D, position in lateral or recovery position to prevent aspiration and use suction as needed. Definitely D is the answer. All right. So lateral positioning reduces aspiration risk. So you want to make sure you put them in that position to allow for the fluid, whatever, water you're putting in, it actually leaks out or drains out. You can also go ahead and suction gently as well. All right. A client with dysphagia should be fed A, in a reclined position to increase comfort. B, upright at 90 degrees, small bites, thickened foods or liquids per speech therapy. C, rapidly to finish quickly. Or D, with thin liquids only. Okay, B, upright at 90 degrees, small bites, thickened liquids per speech therapy. Nice. Okay, so if you have a patient that is having difficulty with swallowing, what test are you anticipating to do? So you have a patient that comes in, what tests are you anticipating to do before you start any feeding? Yeah, so B is the answer there. So you have this patient that is having difficulty swallowing. What test are you anticipating, or what test can you do to make sure, you before you start feeding? Because sometimes, you might have them having the dysphagia, but sometimes they can actually swallow without any problems. What test are you going to be doing for this patient? Okay, speech therapy. Anything else? And check to make sure they're alert, yes. Okay, but you definitely want to do your swallow test, all right? You want to do your swallow test. All right, speech therapy basically looks at how they communicate their, and their voice, sometimes swallowing, but definitely you want to look at your, the swallow test itself as well. So you always try to give them that little sip of water and all to try to make sure that they're swallowing properly, all right? Lord, Blessed K. Hi, Blessed K. Welcome, welcome. All right, so definitely. So upright positioning and thickened liquids plus small bites reduce aspiration risk. All right. A terminal patient requests no CPR and no feeding tubes. What's the best documentation? A, note verbal request only. B, document advance directive, DNR, and notify care team. Confirm orders per facility. C, ignore unless family objects or place the DNR order without discussion. So B, okay. B, Panther Walk, welcome. Welcome, B. All right, so definitely document patient wishes, ensure proper orders are in chart, and communicate with team. All right, so that's the most important thing. So always when you get your patient, always make sure you check in what their code status is. Most of the time it's in the chart. All right, make sure you check their code status and just make sure it's in the chart. You know, if you don't see it, always talk to them regarding it. What's their code status? So at least we can, you know, observe their wishes. What is the best method to prevent pressure injuries in immobile patients? A, reposition every 8 hours. B, use only pillows with no repositioning. C, reposition at least every 2 hours. Use pressure relieving surfaces. Assess the skin daily. Or D, reduce fluid intake. C, reposition every 2 hours. Okay. Nice. So frequent repositioning. All right. Pressure redistribution devices and skincare to prevent pressure injuries. All right. All right. A patient with end-stage renal disease complains of severe pruritus. What is the nursing interventions you're anticipating or you'll be doing? A, encourage hot bath to relieve itching. B, use cool bath, topical emollients, control phosphorus, and consider antihistamines per order. C, tell the patient itching is psychological. Or D, apply alcohol to the skin. All right. So B. Okay, nice. All right. So yes, you definitely want to go ahead and use cool bath, topical emollients, control phosphorus, and consider antihistamine per order. Why do you think this patient is having this itching? Why is this patient having the itching? What do we know? What's the relationship with the itching and end-stage renal disease? What's going on? What is causing all of this itching? High urea levels deposited on the skin, definitely. No faith. All right, not eczema this time around. All right, so it's a buildup of those toxins. All right, the uremia. So a lot of these patients tend to be uremic. All right, they tend to have high phosphorus level as well. All right, and because of the fact that, you know, their system, they cannot excrete their waste products, everything is going to be elevated. Your potassium is going to be elevated, so they're at risk for your arrhythmias as well. So you have to just make sure you're treating those patients. So your phosphorus binders are pretty good. You understand? Try to get them to dialysis, because at most of the time when they become uremic, they need, you know, emergent or urgent dialysis. All right. You can always go ahead and do your regular skincare as well. But the other ones, like, you know, the hot bath, that is going to cause worsening. All right. It's going to cause worsening. Tell them if the itching is psychological. It's not psychological. All right. It's not psychological. All right. So definitely be on the lookout for that. All right. So use cool bath, as we say here, for the patients that are your end-stage renal and is having those itching. All right. So cool bath and emollients reduce pruritus, manage metabolic contributors like hyperphosphatemia. What acid-base imbalance do you think this patient will be in? What's the acid-base imbalance you're anticipating for this patient? Thank you for the follow. Remember to go ahead and like up the live. Thank you. All right. See, metabolic acidosis, alkalosis. Okay. So which metabolic imbalance, which not imbalance, which acid-base imbalance we say, it's going to be metabolic acidosis. All right. A lot of times your renal patients are in metabolic acidosis because their kidneys cannot excrete all of that hydrogen. All right. And so the hydrogen ions. All right. And so they tend to become acidotic. All right. So I see everybody here saying A already. A patient with an NG tube for decompression develops abdominal distension and projectile vomiting. The first action is A, check tube placement and patency. Aspirate and relieve blockage. Notify the provider. B, irrigate the tube with water. C, remove the tube immediately. Or D, feed the patient. Hello, Aston. All right, so everybody says A, check the tube patency and placement. Aspirate and relieve blockage. Notify the provider. All right. Apart from aspirating, what other ways you can actually check your tubes for placement for your NG tube? How do you check for placement for your NG tube? X-ray. Okay. X-ray. Does LPN and RN do the same NCLEX? No, Nats. 2 different NCLEX. All right, 2 different exam. You do your pH level as well, definitely. And if you're aspirating, then you're definitely aspirating and looking for stomach content. All right. Not a problem, not a problem. All right, nice. So we have here, so yeah, assess the tube function, position, obstruction can cause vomiting and requires prompt management. What are some contraindications to you placing an NG tube on a patient? So you have a patient that is to get a NG tube. What are some contraindications for placing that NG tube? Why wouldn't you put in that NG tube for that patient? So I see here, difficulty eating. Contraindication, why you want to put it in? What? Okay, I see skull fracture here, nice. So those are reasons why you would put it in. If the patient not eating, then, you know, you can always go to your NG tube. So skull fracture is one of them. Anything else we're thinking about? Burns. Yes. Could think of the burns as well. All right. You think about your patients that are very, very high risk for bleeding. So depending on their platelet count as well, you can always look at that and say, okay, then, well, doc, I'm not going to put in this NG tube because the platelet count is low. You understand? So definitely you'd want to take that into consideration. You have your patients who have like esophageal varices. So if they have a history of that, you definitely don't want to push any NG tube down that person's, you know, nose and cause any bleeding. All right, you don't want to cause any injury to those varices there. Some persons probably would have just had surgery, GI surgery, gastric surgery. So depending on what's going on, you can always look at that. All right, because you don't want it to be a case where you're inserting those the NG tube and causing any issues with their recent surgery. All right. And sometimes if they have like deviated septum, that is another one you can also think of. So that's why it's always good sometimes to just, you know, acute intestinal problems. I probably would put a question mark beside the acute intestinal problems because that's a little bit generalized, I would say. So you have to give it a little bit more, you know, be a little bit more specific, ACOM. All right, be a little bit more specific. All right. Yeah, so make sure pancreatitis. No, no, that's not a contraindication. Pancreatitis, no. Pancreatitis wouldn't be a contraindication for. Alright. But anything that makes it difficult for you to insert, you know, sometimes they probably have nasal polyps. They have nasal surgery. That's another thing. So depending on, you know, if they've had surgery on their nose before, that is probably a contraindication. So anything that is going to be, you know, making them at risk for bleeding is a contraindication too. All right. All right. For a patient undergoing hemodialysis, which nursing action should be avoided pre-dialysis? So you have a patient undergoing hemodialysis, which routine nursing action should be avoided pre-dialysis? A, withhold antihypertensive medications per prescription. B, obtain weight and vitals. C, start IV fluid bolus without order. D, verify vascular access. A, withhold antihypertensives per prescription, okay. C, start IV fluid bolus without order, okay. So I see a few persons, then one person with a C with a question mark, okay. All right, so starting the fluids without orders can worsen the fluid overload, so follow the dialysis protocol. All right. So let's go back to the question. So start IV fluid bolus without order. All right. And so that's the one that should be avoided. And the fact that this patient is on dialysis, all right, this patient is already at risk for fluid overload. So yes, omidi. All right. So starting the fluid bolus, depending on what's going on, you know. So this patient is already at risk. So you have to just be very, very careful. Make sure it is, if you're doing the fluid bolus, make sure it is a certain amount and nothing that is going to cause further worsening of this patient and their fluid overload. All right. So starting fluids without orders can worsen fluid overload. So follow the dialysis protocol. All right. A patient on warfarin has INR 5.5 and is asymptomatic. What is the best nursing action? Hold warfarin, notify provider. All right. Vitamin K may be indicated depending on the risk and the protocol. B, give full dose and recheck weekly. C, increase warfarin dose. And D, discharge the patient. All right, so A, hold warfarin, notify provider. Vitamin K might be indicated depending on the risk and the protocol. Okay, nice. And what's the reversal agent for a patient that has been overdosed on warfarin? Nice, your vitamin K. All right. And if you had a patient that was overdosed on heparin, what's the reversal agent? If you have a patient and the patient has overdose on, okay, nice, a protamine sulfate, okay. So what medications would you encourage a patient that is taking warfarin to avoid? So the protamine sulfate is the reversal agent for your heparin. Okay, nice. Yes, they're at risk for bleeding. Okay, so yes. All right. So they avoid NSAIDs. You give your vitamin K to help with that. Reversal as well, okay, for your warfarin patient. All right, nice. What foods would you encourage them to avoid? What foods would you encourage them to avoid? Green leafy vegetables, nice, yes. All right, because it reduces the effectiveness of the medication. Leaves, yes, nice. All right. Spanish. Mighty, welcome, welcome, welcome. I don't know what the Spanish is. All right, but the green leaf. All right, so the green leafy vegetables, so anything like, I think, not avoid, just take on limit. Well, yeah, but you just have to, oh, spinach, you were saying, okay. Yes, but you know, sometimes some of us are not that good with, you know, making sure we're eating the right amount. And so if you tell a patient to limit, sometimes consistent amount. Okay, so Carousel says NCLEX says they should maintain consistent amount. Okay, all right. Because they don't want them to overeat on certain things and then the medication not working. All right. All right, thanks for that, Carousel. All right. So let's go down to this question. Elevated INR increases the risk for bleeding. Hold warfarin and notify provider. Vitamin K might be considered per protocol. All right. A patient develops wheezing and hypotension after antibiotic infusion. The nurse should A, slow infusion and monitor. B, stop infusion, maintain airway, give epinephrine per protocol, activate emergency response. C, finish infusion and chart reaction. Or D, administer antihistamine only. B. Nice. What are you thinking is going on here? What is going on with this patient that is getting this antibiotic? Allergy, anaphylaxis, yes. All right. Allergic reaction, definitely. What's the giveaway here for this one? Well, we say anaphylaxis, hypersensitivity. Okay, nice. The wheezing, nice. Airway obstruction, airway, nice. Okay, and the hypertension. All right, nice. So definitely, so we will stop the infusion, maintain airway, give epinephrine per protocol, and activate emergency response. Okay. All right, so anaphylaxis requires immediate cessation of offending agent, airway support, epinephrine, and emergency response or measures. All right, a diabetic patient on insulin glarine. What is the best education for that patient? A, glarine is given with rapid acting insulin for mealtime coverage. B, glarine is only for type 1 diabetes. C, glarine can be mixed with short acting insulin in the same syringe. Or D, glarine provides basal insulin and has no pronounced peak, given once daily at the same time. All right, so let's see, D, 1C. All right, so the C can be mixed with short-acting insulin in the same syringe. And everybody else says D, provides basal. All right, this is a long-acting basal insulin. Consistency in timing is important. It should not be mixed with any other medication in the same syringe. All right, it's long acting, has no peak. Nice, nice. All right. What's the onset for your short acting medication, your short acting insulin? What's the onset? "30 minutes, nice, okay. "30 minutes, hold on there. See somebody say something. What happened to this here? Hold on there. I think I saw a question somewhere. See something about a glaring. Okay, is glaring given at bedtime? Is glaring given at bedtime or morning time? When is the best time to give it? Sorry, hold on. Hold on 1 minute. I'm gonna mute this. All right. So morning before breakfast, bedtime. So bedtime is the best time. Evening time is usually the best time to give your glarine, all right? And then sometimes depending on, if their glucose is like low, if their glucose is usually low overnight, then sometimes they'll give it in the morning as well. So it depends on the patients and the glucose level. All right, what the readings are. So sometimes I can give it like in the morning, 7 to 8, sometimes in the nighttime around like 8, 9 o'clock. So depending on the patient's reading throughout. All right. We only give it once daily. Who was saying that again? Morning with breakfast. Okay. All right. And then for your NPH, what two insulins can be mixed, or which two insulin do you mix, or in terms of the cloudy insulin and the clear one, which one do you pull up first? If you're mixing two insulin, which one do you pull up first? Your clear insulin or your cloudy insulin? Your NPH. The regular first, and then you can go with the cloudy one, the NPH. Yes, definitely. So clear first, and then you pull up whatever else you want to pull up. Clear days, cloudy days. Nice. All right. All right. Which IV medication requires dedicated infusion line and central venous access due to vesicant properties? A, normal saline. B, potassium chloride 20 milliequivalent in 100 mils per peripheral line. Vesicant chemotherapy agent. Or D, oral antibiotics. All right, so see B here, potassium 20 milliequivalent. Okay, B. Okay. Potassium through IV. Nice. All right. So the 20. Okay, so I guess this one I was thinking wrong too. So vesicant chemo should be given through central venous accent to reduce extravasation. Okay. All right. So some persons request. All right. So Carousel had said C, Binny, Mama. Okay, nice. All right. So B. Okay. All right. So C is the answer. So which IV medication requires dedicated infusion line and central venous access due to vesicant properties? A, normal saline. B, potassium chloride 20 milliequivalent in 100 mils per via the peripheral line. C, vesicant chemotherapy, example, doxorubicin. And D, oral antibiotics. And the answer here is C, the vesicant chemo should be given through central venous access to reduce extravasation risk. Okay. So this was what I was thinking, why the 20 would have been a little bit too harsh. All right, but I guess if you have to choose between both of them, I think this one, based on what they're saying here. All right, but you still have to be very, very careful with the 20 milliequivalent by peripheral line. A lot of time, they want you to get at least a central line going for that one. All right, so just be careful as well. But this answer is the chemotherapy drug here. All right. All right. A patient has missed 2 doses of phenytoin and now has tonic-clonic seizure. The nurse should A, give next dose only. B, administer loading dose per protocol and protect airway. Notify the provider. C, hold all anti-epileptics. And D, give oral phenytoin in bed. Okay. C, let's see who. Okay, so C, B, A, C. So patient has missed 2. So hold all. So hold all anti-epileptic. So Italian is saying BBA, administer loading dose per protocol. All right, so most persons says B, administer the loading dose per protocol and protect airway. All right, after missed dose and seizure, loading or IV therapy per protocol is often needed. Airway protection is essential. All right. What are we thinking? Why we want to load this patient with it? If you have a patient that has missed their dose of anti-epileptic drug, why are we loading them during that time? So the patient has tonic-clonic seizure. Well, it says no, so I guess, it's active seizures. But what are we anticipating? So the missed doses, okay. All right. So what is one medication? So they're going to be doing the phenytoin because it says no has tonic-clonic. So definitely we'll go ahead with the loading dose of your phenytoin. What are some other medications you can think of? Not necessarily for this patient that is actively seizing, but like, your anti-seizure medications. What else can you use for your patients that are seizing? Your benzos, definitely. Pregabalin. Lyrica. For the... Anything else? Let me look up that one. Anything else we can think of? Not Coumadin. Coumadin. No, not Coumadin. It's a blood thinner. Phenobarbital. You have your valproic acid. You have Tegretol. You have Keppra. Carbamazepine, yes. Pregabalin. And let me see this one. Okay. right, nice. Okay. All right, so definitely administer your loading dose per protocol and protect airway. Notify your provider. All right. Give oral phenytoin in bed. If this patient is seizing, would we be giving anything orally? So that would have been out. That's the giveaway for this one, the oral phenytoin, because this patient is going to be at risk for aspiration, plus probably bite off your finger. You know them way there? Yeah, man. Patient definitely need medication, so you wouldn't withhold it. All right. Give next scheduled dose only. No, you're not going to give the next scheduled dose only. You're going to give the scheduled dose plus, you know, so you load up the patient. All right. All right. So after missed doses and seizure loading, after missed doses and seizure, loading or IV therapy per protocol is often needed. Airway protection is essential. All right. Will we be putting in any oral airway in this patient? Will we be giving any oral airway to this patient? No, nice. Okay, yeah. A patient on aminoglycoside therapy should be monitored for A, renal function and hearing, ototoxicity, B, hepatotoxicity only, C, hypoglycemia, D, bradycardia. So a patient on aminoglycoside therapy should be monitored for A, renal function and hearing, B, hepatotoxicity only, C, hypoglycemia, and D, bradycardia. So A, nice, renal function and hearing, ototoxicity. All right. All right, monitor creatinine and auditory function as well. What is hepatotoxicity? Liver, yes, okay, and okay, I will say auto. All right, what is one medication that causes ototoxicity? What is one medication, antibiotic we know of that causes, okay, so acetaminophen causes hepatotoxicity. Aspirin, your NSAIDs cause your nephro, vancomycin causes your EPA. Okay, gentamicin, nice. So your NSAIDs tend to affect your kidney. So you tend to have like your hepatotoxicity, all right? Your aminoglycosides such as your gentamicin, neomycin, yes, causes nephro as well as ototoxicity. All right, so sometimes these patients will have like hearing loss. And which one I see again? Loop diuretics and aspirin cause ototoxicity. Okay. All right. Your statin medication, your cholesterol medication tend to cause your hepatotoxicity as well. All right. So your atorvastatin, rosuvastatin, those medication. All right. And your vancomycin causes nephro and your ototoxicity. All right. If you have a patient that is on vancomycin or on which other one? Any other NSAIDs, what lab value will you be monitoring for that patient? Which lab are you going to be concerned about? Your creatinine, BUN creatinine. Yes, so focus on your creatinine for that patient. All right. All right. Let's go down to, so aminoglycosides are nephrotoxic and ototoxic, monitor creatinine and auditory function. A lot of times they'll tell you that they're having ringing in the ears. All right. Heparin infusion bolus ordered. What lab are you monitoring? INR, PTT, serum creatinine, platelet. Nice. Okay. Yes, so B your PTT. Nice. And if the orders, if you get an order for your INR, what medication are you thinking this patient is on? Yes. So if you see the INR, you're anticipating that they're on warfarin. Your PTT is going to be your heparin there. All right. So heparin effect monitored with your PTT. So you want to adjust your infusion per your protocol. All right. So you need to know about your heparin protocol. So you can know when to go ahead and repeat and not have your patient on heparin for the entire day. All right, the entire 12-hour shift. You need to draw your lab values and see what the numbers are, and then you adjust your heparin infusion accordingly. All right. All right, so patient receiving IV potassium 40 MEq per hour per pump through peripheral IV complains of burning and redness at the site. The RN should A, slow infusion, B, apply heat and leave, C, continue because it's expected discomfort. D, stop the infusion, assess the site for infiltration, notify provider and restart via central line or a new site. Okay, definitely. You definitely want to go ahead and stop the infusion. All right. So high concentration of potassium is irritating and can cause extravasation. So stop, assess, and change the access. All right. Your potassium. So this patient that is getting potassium infusion, you're at the bedside. What are some things that you'd ensure that is at the bedside for this patient? What are you doing for this patient apart from the IV infusion? What is it that you want to make sure you do prior to starting this infusion? Okay, so we already got the potassium level. Okay, nice. So you want to do your baseline EKG. All right. Monitor the heart. Okay. I'm looking for specific things, like specific words. I'm looking for, so monitor the heart, continue general assessment. How are we monitoring the heart? Nadugine, listening to it, feeling for it, repositioning BP. Okay. Just make sure you put the patient on the ST elevation. The ST elevation, no, not for the for this patient here. But I was thinking, I wanted you guys to say the cardiac monitor. Get the patient on the cardiac monitor. All right, make sure you have your patient connected to your cardiac monitor before starting your infusion. All right. But all of the things that you're saying, the ST elevation on the EKG, that's not what you'll be seeing if you have a patient that is, they're getting potassium. More than likely, their potassium is low. So you want to be seeing ST segment, put the 12-lead EKG. Yes. Yes, so you get your baseline EKG and make sure you leave the patient on the monitor. All right, so you can see the continuous EKG changes. All right. But for this one, the patient is hypokalemic. So what are you expecting in terms of the EKG? So we're not looking for any ST segment changes. What are we looking for on the EKG? What are you going to be seeing potentially on this EKG? Tall P waves, U waves, depressed ST, arrhythmia. Yeah, we'll see some arrhythmia. Okay. QRS widen. Flatten T wave. All right, flatten T wave. If the potassium was, if this patient was hyperkalemic, what are you expecting to find on their EKG? So you have a patient with high potassium levels. What are you expecting to find on their EKG? The peak T waves, nice. All right. Yes. Okay, yeah. So you'll find your peak T waves. A pregnant patient on ACE inhibitor for hypertension should be counseled to A, continue the ACE inhibitor throughout pregnancy. B, stop ACE inhibitor and discontinue and discuss safer alternatives. Oh gee, I never removed that. C, double the dose, or D, add an ARB as well. On the erase, yes. All right, so the answer is there. B. All right, so stop the ACE inhibitor and discuss safer alternatives because ACE inhibitors are teratogenic. All right. So it's contraindicated due to fetal and renal toxicity. Alternatives should be used. All right. What are some examples of some ACE inhibitors? Or how do you identify an ACE inhibitor? Lisinopril, okay. Pril, nice, yes. Captopril, What about some ARBs, all prils? April, okay. Your sartans, nice. Valsartan, losartan, Okay, tell me sartan. Anything that has a sartan, nice. All right. Okay. Lithium toxic levels signs include A, polyuria, tremors, confusion, ataxia, bradycardia only. C, hypoglycemia. D, increased appetite. Okay, A. So we see polyuria, tremors, confusion, ataxia. Nice. Okay. All right, nice. So lithium toxicity presents with neurologic and renal symptoms. Check levels and manage accordingly. They may need dialysis. I remember the word can't. C for confusion. Okay, so lead innovation says, remember the word can't. C for confusion, A for ataxia, N for nausea, T for tremors. All right, to remember that. All right, so you have this patient that is getting lithium. What is one important thing you definitely want to do for this patient in terms of the management? Monitor lithium levels, exactly. All right, make sure you monitor your lithium levels. 1.5, nice. Below 1. Okay, all right. So remember, NCLEX is all about safety. So you need to know the medications that warrants you to do, like, vital signs as well as blood, blood levels before, all right, before you administer them. So like for your metoprolol, what is it that you need to do for your beta blockers before giving it? need to check your heart rate. Nice, nice. Take vital signs, okay. All right, so always try to be as specific, you know, vital signs, but make sure you check, you know, make sure you look at heart rate, blood pressure. Nice. All right. Check heart rate. What are you, what is the range? So for example, the heart rate is 59. Are you going to be giving that metoprolol? 60 to 100. Okay, so you hold it. Nice, nice. Okay. All right. What about digoxin? If you have a patient with hold, nice. Okay, good. The same thing for digoxin as well. All right, good. All right. Just be mindful of those medications. All right. Monitor for digi levels. Watch for yellowing eyes. Monitor below 60. Definitely. All right. So what if you gave the patient too much digoxin? How would you reverse it? Hold it. Check the apical pulse again before giving it. Nice. All right. So if you give too much of the digoxin, how do you go about with reversing it? What are you thinking? Your digibind. Nice. Okay. All right. Add fluids. Yeah, you can give fluids. You can't go wrong with fluids. Well, except, you know, if the patient is overloaded. All right, but Digifab, Digibind is definitely your go-to medication. All right, for your overdose. All right. A patient prepares total parenteral nutrition for a patient. A nurse prepares total parenteral nutrition for a patient. Which monitoring is essential? A, monitor only for allergic reaction. B, only check glucose weekly. C, no monitoring needed. D, daily weights, glucose every 4 to 6 hours, electrolytes and central line side checks. Okay. D, daily weights, check glucose every 4 to 6 hours, electrolytes and central line sites check. Okay, nice. All right, so what if this patient that you have here, daily weights, check glucose every central line. So what if this patient starts developing a fever? The patient starts having a chill. What are you going to be doing with this patient? So you have this patient that has been getting the TPN. The patient starts developing fever, chills. What are you planning on doing for that patient? Check CBC. Stop. Monitor white blood cell count. Okay. Okay, check for infection, definitely. All right. To the CBC side for infection. Stop the bag and tubing should send to lab. Hold, taper down. All right. Okay. All right, so you talk about getting your blood cultures. All right, remember that. All right, remember this patient has a central line. So talk about your blood cultures. I know we said that, you know, CBC and all. But try to use specific words or look for specific words when you're doing the exam. So you look for your get your blood cultures, get that, you know, send off, and then from there. All right. In terms of getting your blood cultures, where do you get your samples from for your blood? What's the correct way to get your blood cultures? Central line access. Okay, nice. Lab central line from the port. Okay. But the port is infected. Why you want to get one from the port? Why? Why you want to get one from there? And take a sample. Flush it. Okay, nice. Why you want to get one from the central line? Why you want to get one from the central line? You want to check to make sure that, you know, who had said it? I see somebody say get one. I just don't want it to be a case where you're just getting it from the central line because you just need one and you have the access. But getting it from the central line for culture and sensitivity to check if the infection is in that line there. Nice. All right. And then you get one from somewhere else. All right. So you always get it from two separate sites. Yeah. I just don't want it to be a case where you're thinking you just get it because you have a line, a line already. It's nice to get it from that one, just like when you have your catheters in, you know, your urinary catheter in. You can always send the tip of that off to the lab to get it checked. All right. So you always want to just check if they have the central line, get that line, that sample from that line to see if if that is the source for the infection. You can always get one from somewhere else. All right. So you get your two blood cultures, different sites. All right. I see some persons say that, you know, like, you know, you'll have, or I see a lot of persons do it. Like they'll get one from the central line and then they'll wait probably like about 30 minutes to get the next one from, like, you know, the arm. Like, so for example, they have one in they put in an IV in the right arm. They wait about 30 minutes before getting it from that second line. And what are your thoughts on that? Do you go ahead and just get it at the same time? Can you get it at the same time, or do you have to wait for the 30 minutes? Who says at the same time? You get it from two different sites and you get the blood cultures. Are you okay with doing that? Is that okay to do? Or do you think it's wait the 30 minutes even though it's from different site? So Beanie says yes. Yes to wait, I think. Okay. It's okay with the same time. Exactly. That exactly. Because it's coming from two different sites. It's coming from two different sites. Even if you get the sample, one from the central line and one from the right arm, the left arm, as long as it's not coming from the same site, it's two different sites. So you can always go ahead and grab your samples rather than introducing that antibiotic or have the patient be waiting 30 minutes before getting it from another site. If you have only one line and you're working with, like the patient is a very hard stick and you have only one line, you only have the central line that you're working with and the central line is not infected, or even if it's infected, you know, and you can't get any another line, what are you going to be doing? You're going to go ahead and make sure you just wait your time. So you get your first sample, you flush it, you get your sample, and then you wait your 15-30 minutes, and then you go ahead and do that. All right, but the 15 minutes you want to just wait because it's coming from the same site. And then from there, you label it with a different time as well. But if you have two different sites, I don't see any purpose of you waiting that 15-30 minutes. All right, because it's two different locations you're getting the sample from. All right, so just to be mindful of that. Sometimes I'll see persons be doing it where they're waiting 1 hour and the patient really needs antibiotic. That is what the patient needs. All right, you can always get the sample and then document on the bottle. You get it from the left arm, the time you got it, and then you can always say that vancomycin was given. So at least the persons in the lab will know that, oh, vancomycin is on board, you know? So that's just it. So D, daily weights. Yes, Zena, daily weights. Glucose every 4 hours, every 4 to 6 hours, electrolytes and central line site check. And the central line dressing is changed every 5 to 7 days. All right, and if it gets soiled before that time period, you always go ahead and get it changed. All right, I remember it's a sterile procedure. All right, so TPN requires close metabolic monitoring due to hyperglycemia, electrolyte shifts, and infection risk. All right. A fast-acting insulin given IV in DKA is regular insulin, which is true. A, rapid acting analogs, Lispro, can be given IV for DKA. B, regular insulin is standard IV insulin. Monitor glucose and potassium closely. C, no insulin needed in DKA. D, give subcutaneous only. B, nice. All right. Regular insulin is the standard. Insulin, monitor glucose and potassium closely. All right, nice. So IV regular insulin is standard. Insulin shifts potassium intracellularly, so monitor potassium. Okay. All right. So what are some of the signs and symptoms for your patients that are in DKA? What is like the classic sign of a DKA patient? Diaphoresis, okay. Sweating, dehydration, acetone breath, yeah, the fruity breath, nice. High osmolarity, nice, okay. All right, along with, yes, hyperglycemia, along with the different P's, the cosmal respirations, fruity, nice, definitely. All right. So you have this patient, LPN, no, but you can still benefit from it. SS heart, all right. You can still benefit from it. Tremors, nice, all right. So for your DKA patient, in terms of your labs, what are you looking for in terms of your blood work? So what is it? So you have a patient that is in DKA, you're going to be treating. What are you going to be looking for? So, okay. So we're looking at ketones, glucose, okay. All right, so you're going to start your insulin. What are you looking for on your labs? So the patient is going to be in metabolic acidosis, all right. Kidneys, nice. So your potassium levels, definitely your potassium levels. All right, what are you looking for in your potassium levels? You want to make sure your potassium levels are normal, all right, within that 3.5 to 5, nice, 5.0, 5.2 range, all right. And if it is at 3, or let's say it's at 3.4, what are you thinking? What are you thinking? What are you going to be doing? Okay. Yeah, we'll do the blood pressure. We'll still monitor. Okay. But if the patient is at 3.4, still monitor, hold insulin, and give potassium. Yeah, because that is like so close. That is like so close. All right. So definitely go ahead and give your potassium. All right, your potassium, and start your insulin. All right. Definitely go ahead and do that. Would you be feeding this patient? The patient says that I am hungry. Will you be feeding this patient a little bit more? High potassium foods. Okay, but no, without this patient is gonna be NPO, nothing by mouth. Alright, can probably put two little ice chips in the mouth. You understand? The patient is gonna be dry, but patient needs a lot of fluid. Alright, patient needs a lot of fluid on board. What do you think about putting in an IV? So for example, not an IV, a catheter on this patient. What if this patient is, 87 years old, 87 years old, a little bit confused. What do you think about giving this patient a catheter? What do you think about putting a catheter for this patient? And Siggy says no. No. Okay. What are you planning on doing? How are you going to take care of this patient, DKA 85-year-old, elderly patient that is getting so much fluid? Yes, you need to do strict intake and output. So go ahead and get your catheter order and get it in. All right. For this patient. This patient would warrant a catheter. If it's a case where the patient is ambulatory and all, which, most of the time they're so weak, then definitely, that's not gonna be for them. But once they are, you know, weak, lethargic, immobile, you know, you want strict intake and output. So go ahead and get your catheter in for that. All right, nice, nice, nice. Oh, I was supposed to ask you guys the other, ask you from the hyperkalemia patient. Let's hear it. So you have this patient you're treating now is a hyperkalemic patient. All right, you're treating this patient that has high potassium. How are you going to be treating this patient? Let's hear it. What are you anticipating in terms of medication wise? Why are you not at bed? All right, okay. So your IV calcium gluconate. Okay, what else are we thinking about? Is this spironolactone? No. So you have two giveaways here. IV calcium gluconate. Okay, yeah. Okay, in terms of medications, what are you thinking about for your treatment of hyperkalemia? All right, so we have your insulin. Insulin, okay. Anything else we can use to treat hyperkalemia, high potassium level? I think Nadia is saying furosemide, Lasix, no. Alright, capsulate, definitely. That is going to cause them to have that diarrhea. Alright, we definitely need the dextrose on board as well. Polystyrene, nice. Yes. Alright. So you need your insulin, your calcium gluconate, you need your capsulate. You can also do your albuterol inhaler. Dialysis, definitely. Alright, so those are different things you can use. All right, so let's look at it. So we have the insulin. Carousel, this is not for you. All right. We have the insulin. We have the calcium. We have capsulate. And we have, which one? Insulin, calcium, capsulate. And we're not going to do the nebs. But I want to hear you and your dextrose. Yes. All right. All right. Benny. I'm going to have you type a little slower, okay? Let's hear it. So which order are you anticipating giving the medications in and why? All right. So I need somebody else to answer. Because I feel as though Binny and Carousel know the answer already. All right. So High Favor Unlimited, I want you to tell me, how are you going to be giving this medication? So you have insulin to administer, dextrose, you have calcium, and you also have your capsulate. How are you going to be going about with medicating this patient and why? Which one first? Okay, so we're trying to figure out, if you're just joining in, we're trying to figure out how we go about with treating the hyperkalemic patient. So we already said we're doing the insulin, we're doing dextrose, we're also doing your calcium gluconate, we're going to be doing capsulate, and possibly some, nebs treatment, nebulizer. All right, so let's start off with the calcium. Why are we doing the calcium first? So remember the patient, I guess Binny and Carousel, can go back into typing as well. But the patient is, yes, leading innovation. You want to stabilize the heart, all right? You want to stabilize the heart because remember, this patient has hyperkalemia. So you have arrhythmias. I just passed my clip. Oh, thank you. Congratulations. So definitely you want to go ahead and stabilize the heart. Remember the patient has high potassium, at risk for your arrhythmias. So you want to make sure you go ahead and start your calcium gluconate to stabilize the heart. All right. Then you go about with are you going to be doing your dextrose or your insulin? Insulin. Okay. All right. And then we'll do the dextrose, insulin and the dextrose. And then we'll eventually go ahead with everything else. All right. Because the insulin is going to do what? Shift the potassium in the cell. And so you need your glucose to act as like a transport. All right. So definitely go ahead and always start with your calcium, then your insulin and your dextrose. All right. Your Kioxalate is going to be your diarrhea. It's going to cause the patient to have that diarrhea. So lose some of that potassium through their stool. And you can also, oh Lord, let me get back over there. Which side? Okay. And you can also do the nebulization treatment sometimes, if the medication is not working. You can always go ahead and do your nebs treatment as well. All right. So let's move on to the other one. All right. Which diuretic is a potassium sparing? A, furosemide, B, hydrochlorothiazide, C, spironolactone, or D, butanamide. C, spironolactone. Okay, nice. Let's see, C. Okay, all right, let's see, B, did somebody say B? Okay, so I guess everybody's saying C. All right. All right, what's another name for furosemide? What's the other name? Alternate. Lasix, nice. And what kind of drug is Lasix? What class of drug is Lasix? Your loop diuretic. What about your bumetanide? Your loop diuretic, nice. Potassium wasting. What's another name for your bumetanide? The diarrhea. See? Bumix, nice. Alrighty. So spironolactone is a potassium sparing. All right, others are potassium wasting. All right, a patient on warfarin is started on antibiotic known to potentiate warfarin effect. What is the nursing priority? A, continue usual warfarin dose and ignore the interaction. B, monitor INR more frequently and notify the prescriber for dose adjustments. Or C, stop antibiotic or stop warfarin permanently. So you have a patient on warfarin that is started on an antibiotic known to potentiate warfarin effect. What is the nursing priority here? B, monitor INR more frequently and notify prescriber of the dose adjustment. All right. A client with recent MI reports chest pain and diaphoresis. What's the first action here? A, administer schedule and acetaminophen. B, assess vital signs, EKG, give oxygen if hypoxic. Administer aspirin per protocol and notify. C, document and observe. D, send client to radiology. Okay, all right. Okay, so we have the EKG, oxygen, aspirin. All right, so you do all of those. What is missing from this? You assess first. Nice. Okay. All right. So you have this patient here. All right. Patient is having chest pain. All right. Patient is having chest pain. In terms of medication-wise, for the pain, what are you anticipating for treatment for this patient, your nitroglycerin. Nice. Okay. How much doses can you go on your nitroglycerin? Nitro, 3. Okay. 3. Okay. Nice. Okay. Okay. Yeah. All right. What are you anticipating in terms of with the nitroglycerin and the blood pressure? So every 5 minutes for up to 15 minutes. Okay. Nice. What are you anticipating in terms of with your blood pressure? What are you anticipating? It lowers your blood pressure. All right, so make sure your patient have an IV, please. All right, orthostatic. Make sure your patient have an IV. All right, you can always have a little fluid ready just in case. All right, a lot of these patients tend to have a little blood pressure, not blood pressure, headache as well, which is usually because of, you know, what kind of drug is your nitroglycerin? What class of drug is it? It's a vasodilator. Yes, all right. So it's a vasodilator nitrate, okay? So beta blocker. Okay, all right. So it's a vasodilator. So the patient tends to have, like, you know, a lot of them will complain of the headache, all right? You'll have the blood pressure dropping as well. All right, Essie, I see the ventilator. I figure more or less you're saying vasodilator. All right, we'll read between the lines. All right, so you give this patient the 3 tablets. The patient is still having pain. What else can you think about to give this patient for the chest pain? What other medication can you get on board based on the protocol for ACS? You're fine, Geraldine. All right, so the patient already got the aspirin. The patient has gotten the 3 doses of the nitro. All right. Patient has gotten a 3 doses of the nitro. Nothing. What about your Mona? You remember your Mona? Yeah, your mnemonic Mona. What is missing from there? So patient already got the oxygen. All right, patient has gotten the oxygen based on B. Answer B. So you already did the vitals, EKG done. Patient is already on oxygen. You gave the aspirin. I would just give the patient a 3 doses of aspirin. But the patient is saying, nurse, you know, my chest still a kill me. What can you do for that patient? Oh, my chest is still hurting. What can you do for this patient? Okay, cardiac monitor, your morphine, all right? Not a problem, Geraldine, thank you. But remember your morphine, all right? So a lot of times if the patient has got the nitroglycerin and, you know, they're having the pain after the 3 dose, a lot of times the morphine will help with that, all right? So always go ahead and give your morphine. Based on ACS, all right? Your morphine, your oxygen, nitroglycerin, and your aspirin, all right? So always anticipate that. All right, so the time-sensitive interventions, what are we thinking about there in terms of blood work? What labs are you monitoring for? So this patient is having chest pain. What lab are you thinking about? Your troponin, nice, your troponin, all right? Your troponin, okay, nice. So what if this patient, you know, you're there and you realize, yeah, the patient is diaphoretic, the patient is having chest pain, but when you look at the lower extremities for this patient, the patient has significant swelling in the lower extremity. What lab can you think about that you'll draw for this patient apart from the troponin? So the patient has edema, okay. The patient has edema. What additional lab can you you can draw for this patient? So creatinine, B1 creatinine, CK, your BNP. Yes, Mali. Definitely. So yeah, we'll be looking at the electrolytes, you know, creatinine, BUN, definitely CK, your D dimer. Okay, you can get your D dimer if you're thinking about like a clot, but with the leg swelling, if you have a patient that is having, you know, significant leg swelling, what are you anticipating that is going on in terms of diagnosis? Okay. Not thinking along the line of a DVT. I'm thinking along the line of a, who's that? C? All right, so CHF, nice. Okay, so the fluid overload, all right, especially if it's bilateral. All right, if it's bilateral, a lot of times if it is DVT, sometimes it's like, you know, unilateral. So you're definitely looking for your BNP to add to this patient. If you realize that the legs are swollen, you go ahead and get your BNP and send it off as well. All right. Your D-dimer is most of the time for your patients when you're thinking about clots. All right, you get a D-dimer for that patient. Nothing is wrong with getting the chest pain, you know, this patient, the D-dimer as well. All right, and then from there. All right. So for the CK, I saw someone said the CK. Which of the CK, the creatinine kinase, is going to be a little bit specific to the chest pain? Which of the CK are you looking at? Mm-hmm. Okay. All right. Yes. Was she the same one? Okay. So if you have to choose between your CKMB, all right, your CKMB and your troponin for your patient here, your chest pain patient, which one is going to be more specific for your chest pain? Your CK or your CKMB or your troponin? Yes, all right, yes. Because sometimes you can have a false positive because of some skeletal, like, you know, injury, muscle injury. So say, for example, you have your patients that have like rhabdo, you can probably have an elevation in your CKMB because of that. All right, so if you have if you have your troponin and your CKMB and they're asking, you know, which one is, depending on what is going on with your patient, the troponin is more specific to the heart muscle. All right, and then from there, what else can we think about with this question? All right, so you have this patient. Where are you anticipating this patient going? So the patient is still having chest pain. You notice that there are EKG changes. What EKG changes are you anticipating for this patient? What EKG are you changes are you anticipating? Your ST segment changes, elevation, nice, yeah. All right, nice, nice, nice. So probably this patient, depending on what's going on, probably this patient ends up going to the cath lab. All right. So suspected infarction, reinfarction is required immediate assessment and time-sensitive therapy. All right, and the MONA, the morphine, oxygen, nitroglycerin, and aspirin as appropriate, and provide a notification. Okay. Send the client to radiology. So this patient is having chest pain. Would you accompany this patient to the radiology department, or would you just put the patient with transport and ship over to radiology? You would accompany this patient to radiology, Jazz? Yes, nice, nice. Definitely. You'll go ahead with this patient to radiology. All right, make sure you put the patient on a cardiac monitor and you accompany the patient. All right. All right. A patient on digoxin has nausea, visual disturbances, and bradycardia. What is it that you're suspecting? A, digoxin toxicity. B, hypothyroidism. C, normal side effects only. Or D, allergic reaction. Digoxin has, okay, so A, digoxin toxicity. So you check the level, hold the medication, and notify the provider. Okay, nice. For a patient with hypothyroidism, though, what are you anticipating in terms of their signs and symptoms for someone with hypothyroidism? Brittle hair. Cold intolerance. Nice. Fatigue, weight gain, constipation, changes with their calcium. Nice. All right. Yes. All right. So the metabolic rate is slow, so everything's slow down. Heart rate. Okay. So GI and visual symptoms plus bradycardia are classic signs for digoxin toxicity. So you want to check the level and manage. All right. And I know we have some persons that just joined us. Welcome, welcome, welcome. How would you go about and treat this patient with digoxin toxicity? What's your antidote? I know we said it earlier, but let's see. Some new folks putting in an answer. You digifab, nice. Digibind, okay. All right. So this patient, you'll anticipate doing that. You get your levels and you manage. All right. All right, so the pre-op consent is valid if A, the patient signs the form under sedative influence, B, the nurse signs in place of the patient, C, family signs instead of the patient without documentation, or D, patient is competent, informed, and not coerced, consent obtained after explanation of risk and benefit and alternatives. All right, nice. D. Okay, all right. So make sure that the patient is competent, informed, and is not coerced into signing anything. Okie dokie. All right. Sedation negates capacity. All right. So the patient is under the influence. Don't get any consent from them. All right. Prior to administering blood, the nurse must A, verify with another RN the patient ID, blood product and compatibility, baseline vitals. B, start infusion without checks if busy. C, warm blood to 45 degrees. Or D, allow family member to check identification. So before you administer blood, the nurse must verify with another RN the patient ID, blood product and compatibility, baseline vitals. Okay, so two-person verification and the baseline vitals are required to reduce transfusion reaction errors. Okay. All right, so what if you're there and it's an emergency, patient bleeding out and the blood is available? What will you do? You're alone on the floor. What are you going to be doing? The nurse is not there. Only you alone. You have a CNA or you have a LPN. Patient blood is there. Patient need the blood because the hemoglobin is what? 5, let's say 3. What are you going to be doing? You warm it up. Okay. Yes, we go ahead and make sure it's room temperature. All right. Hi, Mona. Check with the LPN. Is that so? What are you gonna do? So you have this patient whose blood is hemoglobin is low. All right, and then you have the blood available. So hemoglobin is what, 3? Let's say the hemoglobin is 3. You alone on the floor because the nurse, she ran to the bathroom and she's there taking forever. Because probably she on TikTok or watch me right now. You understand? And then you still need to give the blood. But 1 hour pass, you know, the patient is still there. Wait, okay. All right, so you can always call your supervisor and see if somebody will come down. A lot of times they're available as well. All right. Turn blood to bank. Return, no man, you're not return the blood. Call the supervisor. Sometimes, you know, they're available. They will come down and help out with, yes, call sister. Which hospital you come from, K Myers? Hey, call sister. Sister always available. So call them and let them know. You understand? But you definitely need 2 RN. You call the charge nurse. Yes, you call the supervisor and let them come down. Let them know what is going on. And from there, they will come and assist with getting that blood started. All right. So you call the sister on the floor. Let's hear how you're going to be call another charge nurse. Yes, yes, yes. Was going to say regarding the S-bar. I missed the question. Oh, we're talking about the blood transfusion, the 2-person verification. All right. So, you heard about the, you know, you're calling this provider. You're calling this provider. You're calling the charge nurse. The nurse is not familiar with the patient, and you're gonna be, you know, telling the nurse about what's going on. Using the S bar. What is the S for? Are you familiar with that? What is the S in S bar for? When you're doing handoff, proper handoff. All right, so definitely, what's the S for? Your situation. Okay, nice. Because remember, this nurse is over by psych. The nurse have no understanding as to what's going on your, you know, cardiac floor. So you want to use the S bar to give her a little bit of an idea as to what is going on. You know, can always go ahead with your situation. What's the B? What's the B in S bar? Your background, nice. All right, so you give a little bit of information regarding the patient, what you're gonna be doing. Your A, situation, background. Your A, your assessment to let the nurse know that, oh, the hemoglobin is low, blood is available, nurse not there, things like that. Whatever you want to put in there, but at least use that to guide your handoff. And your R is for, you know, what is the R for? Your recommendation. All right. So always try to use that when you're doing your handoff. You're on the phone, you know, calling another doctor. Probably that doctor or provider is not the one that saw the patient, and you need to give them a rundown as to what's going on. Use that mnemonic to go about with, you know, handing off your patient or giving the information. All right. So okay, so you check with the RN and you're doing your blood transfusion. You know, you start your transfusion without checks if busy. That's a no-no. All right, you always need your pre-transfusion and your post-transfusion vitals. All right. And then you need to do your 15 minutes check. All right, your first 15 minutes is stay at the bedside and you observe the patient. All right. If you notice that this patient is developing hives, the patient is having shortness of breath, or they're like, oh nurse, I feel as though there's a lump in my throat. What are you going to be doing? You look at the patient just looks like the patient have a lot of rash over. What are you going to be doing? Patient is having an allergic reaction. So you stop immediately. Okay, nice, nice. Assess airway. Okay, airway looks fine. Patient is like, nurse, yeah, I just feeling a little bit of, you know. So you stop. Okay, so you stop the infusion. All right, so you stop on fluids. So what are you going to be doing with the blood? Return to bank. Okay. All right, so you take off the blood. So you take off the blood, you discontinue the blood, you still have the line there. And you decide that you're going to give some fluids. Where are you going to give this fluid? How are you going to administer this fluid? All right, so blood work again. Return. Assessment contacts, send back the whole thing to blood bank. Okay. Normal saline. Okay. Are you going to be giving it through, where are you going to give it? Another place. Nice, Gertrude. Yes. you're gonna make sure you give it through another place. So you want to go ahead and take out that line and give it through another line. All right, so make sure you take out the IV and everything. So that's why it's always good to make sure you have the 2 large bore IVs when you're doing your blood transfusion. All right, so always get it in the crease, the AC. Always get it in your AC if you can. Not on the big finger, not on your thumb. All right, try to get it on your AC, not on your wrist. All right, always get a large bore IV, and then from there, it's always the white tubing. I think I missed that. It's always the white tubing, Nadogene. I don't really understand that. So I know the white tubing, but if the patient is developing a reaction to it, you want to go ahead and just take out the line completely. All right, take out the line completely. But I always say, if you only have, you know, for example, because some patients are just difficult to take, and you have the one line that is working, you know, you have the reaction, the patient develops a reaction. I always say, don't take out the line it until you get a second one. All right, if you can pull back, whatever you can pull back, try to pull back and waste, but try to always see if you can have a line in the vein. All right, yes, you're not going to introduce anything to it, but at least you still have something that is closest to the heart. Because if you take out that one and the patient don't have any, and the patient is having a reaction, what are you going to be doing? All right, so always make sure you get your second line first, and then from there. All right, so keep the IV line open just the same. All right, but you're not going to be introducing anything, because even if the patient is developing a reaction, you know, if you kind of wait out and look at it, whether or not the patient will have a reaction, but at the same time, the patient is dying, you can always go ahead and push your epi. You know, so just think of it like that. It's still a route that is very close to the heart, so you still can use it for your medications that are, you know, the patient definitely needs. So always get your second IV, and then from there, you remove your, you know, the one that you're not going to be using, and then you get another one. All right. Warm blood to 45. Nice. Okay. Do you put the blood in the warmer that we put the linens in? Or do you have a specific area that you warm your blood? Do you hang it out with the bed linen, the blankets and the gown and all them stuff there? No, no, definitely not. All right. Definitely not. All right. So, all right. And then that would have been it. So you send back everything to the lab, and then from there you treat the patient based on what is ordered and all. All right. So we said 2-person verification and baseline vitals are required to reduce transfusion reactions / errors. All right. A patient with a new ileostomy reports high output, diarrhea, and dizziness. All right, the nursing intervention is to A, change ostomy bag more frequently only, B, restrict all fluids, C, encourage fluids with high potassium and sodium, assess for dehydration and notify provider, or D, ignore the patient or ignore the whole, you know, high output because the output is always high. What's your answer? C, encourage fluids with high potassium and sodium, assess for dehydration and notify the provider. Definitely. All right, so you want to make sure that you do your fluid and electrolyte replacement. With this patient, what acid-base imbalance are you thinking this patient is in? What's your acid-base imbalance? Okay, so you want to definitely prevent dehydration. So you do your fluids and electrolyte replacement. All right, so this patient, hyponatremia, okay. Metabolic alkalosis, okay. Anna wants to see the question. So a new patient with a new ileostomy reports high output, diarrhea, and dizziness. Okay, okay, so metabolic alkalosis. All right, nice. Patient losing the potassium, sodium, all right, and is at risk for those. So you don't want to ignore it because output is always high. No, output is always high. That's a red flag. So make sure you keep an eye on that patient and do all the necessary checks. All right. Change the ostomy bag more frequently. Only. No. Anytime you see any answer with only. All right. Always ignore that one. All right. Because it's always wrong. Restrict all fluids. No. This patient, you want to make sure you're giving a lot of fluids because the patient is having high turnover in terms of diarrhea, dizziness, losing a lot. All right. So this patient is at risk for dehydration. All right. And this patient, it might sound, it might sound like nothing, but you still need to put this patient on your cardiac monitor as well. All right. Still need to put this patient on the cardiac monitor as well because patient losing a lot of potassium, so it's at risk for your hypokalemia. All right. So if you have your patient and this patient is at risk for hyponatremia, so we know about the magnesium too. Nice. Yes, Mona. So this patient is low sodium, so hyponatremia. What are you anticipating in terms of the signs and symptoms for hyponatremia? What are you anticipating? Okay, seizures. Okay. And Mary, what else are you doing? You're checking for, or what are they gonna be having? Fluid overload. Headache. Okay. Tachycardia. They might be lethargic. Okay, nice. Confused. Hypertension. We're talking about hyponatremia, low sodium. So this patient is at risk for hyponatremia. All right, got to monitor INOs, definitely. Okay, but this patient is basically gonna be like dry, diaphoresis. Okay, they're gonna be confused, nervous, lethargy, dry mouth, bradycardia. Okay, all right. Because sodium is low, increased taste, skin turgor. All right. A client on chemotherapy develops neutropenic fever. What is priority action here? A, delay treatment until coma. Okay, coma, dry mucous membrane, definitely. All right, so priority actions for this patient that develops fever, or no, the patient is on chemotherapy. What is the priority action? A, delay treatment until the count recovers. B, observe at home. C, give acetaminophen only. D, start empiric broad spectrum IV antibiotics after cultures. Isolate and monitor. Monitor for infection. Nice, nice, nice. Yes, so D. All right, so you're going to do a sepsis workup on this patient because is neutropenic fever emergency, oncology emergency? Is it an emergency at all? Is it something that you'll be like, okay, ma'am, I'm going to have you just take some Tylenol and then go back home? Closed door and infection is risk. Okay, so yes, it's an oncology emergency. All right, so you definitely want to make sure you start working up this patient, get your blood cultures, lactic acid, fluids, all right, antibiotics, and then from there, so we see here, isolate. What kind of precautions are you going to be having for this patient, or what PPE are you anticipating using for this patient? They will be immunocompromised. Nice, nice. Okay, what kind of precautions you'll be using for this patient? Immunocompromised. Room isolate. Okay. Reverse barrier. Neutropenic reverse barrier. Nice. Mask maybe with visitors. Okay. Are these patients open to getting flowers? No live flowers, no raw vegetables. Definitely. Nice, nice. All right. Okay. Strict hygiene. Yes. So what if everybody this so for example the family is a huge family, you know, and you see a family of 12. 12 persons come to visit this one special patient. What are you gonna do? Let me hear what you would say. So you are on the floor and you see 12 visitors come along. You know, and they're here for John Doe in room 10, and you know that John Doe is on neutropenic precautions. What are you gonna do? Avoid crowds. Yes, restrict visitors. All right, restrict the visitors. So find out who is gonna be the person who is gonna be communicating to the family. All right, so educate them, definitely educate them and let them know that this is what is going on, and in order to protect your loved one, then you know 11 or 10 of you guys gonna have to probably wait back outside and visit probably next week. You understand? Because then you don't want it to be a case where every day somebody new come into this room. So have one person who's going to be like the point of contact, and that person can visit. Sometimes, you know, you might end up mixing up because visitors have to work and all of those things. But when you can restrict, you know, the amount of persons that are going into that room, then that will be good. All right. And I always tell them, most of the time they will be, you know, open to it, especially when you tell them it's protecting the patient, especially to protect the patient. A lot of times they're open to it. All right, it's just how you go about with delivering the message. All right, and then from there, one spokesperson. Yes, one person can go in or two persons can go in, and then from there, they're the ones that are gonna be getting that information to them. But in terms of the amount of persons going into the room, you just want to limit that a bit. All right. But definitely you want to go ahead with your antibiotics, fluids, isolate, monitor, make sure patient always wearing the mask, you know, the precautions, doing all of those. Delay treatments until the counts recover. No, you know. Observe at home, definitely not. This patient will be admitted. Give acetaminophen only. No. All right. Strict hand hygiene. Yes. All right. So neutropenic fever is an oncologic emergency. Prompt cultures and empiric IV antibiotics are required. All right. You have a patient that has sudden unilateral weakness and slurred speech within the stroke window. Which is priority? A, time last known well. B, wait to see if symptoms resolve. C, give aspirin before imaging automatically. Or D, start heparin. So you have a patient with sudden unilateral weakness and slurred speech within the stroke window. Which is priority? All right, so I see 1C, give aspirin before imaging automatically, and then I see A, time last known well. Okay, nice. All right, and the time we're looking at is, what is the time we want to hear? What is the number? If I see Rima, says 3. So in order for them to get the TPA, that blood clot clot buster, the TPA drug, what time period are we looking at in terms of the window? The 3 to 4.5. Okay, nice. All right, so at least within the 4.5 there, you want to make sure that we know when it was the last time they were well known as being normal looking. All right. So definitely we're thinking about a stroke here. So stroke protocol requires time of onset and immediate imaging. Interventions depend on type and timing. All right. So this patient comes in and the patient is having that. So I see somebody saying the fast. What is fast? What is fast? What's that mnemonic for? What is it? What's the F for? What's for TPA? You have to know what type it is. Yes. Yeah. So facial droop. Okay. What's the A for in fast for your stroke patient? your arm, okay, and then your S, arm drift, arm, your S, arm weakness, nice. It's for speech, good. All right, so slurred speech, things like that you look at, and the T is the time. All right. Yes, okay. All right, so always make sure you know your NIH. All right, get your initial NIH before. All right, so you can always get that while you're heading over to CT. Know your initial NIH. All right, before you start anything. I see someone says here, but you have to know, where is that? Someone says, but yeah, but for TPA, you have to know what type it is. Yes, you have to know what type it is. So you have to get them over to CT to get that dry scan. In that time period, they still can get your NIH. All right, and then from there, what if you realize that, what is one thing that is important that you need to get for this patient? All right, one thing that you definitely need to get for this patient. So, oh, the answer there is A. The answer for number 80. All right, the answer is A for that page, for that question there. All right. NIH is your stroke scale. All right, NIH is your stroke scale. So the National Institute of Health, they have a stroke scale that you use for your patients. All right, so CT scan, NIH, okay, you definitely need all of those. All right. Okay. So yes, you want to know whether or not it is ischemic for TPA. All right, so you need to get them to get that dry scan as soon as they step in through the wherever they're coming from, emergency room. All right, but what is one thing you definitely need for this patient? So this patient is having sudden unilateral weakness and slurred speech. What else do you need for this patient? Okay, oxygen, if the oxygen level is low. What else you need for this patient? Heparin, when I reach the say yet. The patient's still in the CT room. What else you need for this patient? Precautions. Oh, yeah. IV. Yes, we need all of that. Blood glucose. Yes, Benny. We need the blood glucose, because what if this patient is having a this patient glucose is just low, hypoglycemic? Huh? What if this patient glucose is low? You want to make sure that this patient is not hypoglycemic and having signs and symptoms of, a stroke. All right, so make sure you get your glucose on arrival. That is very, very, very important, as well as to the CT room. All right, but the glucose is very good, because sometimes you'll realize that the glucose is like what, 30. And by the time you give the patient, you correct that. If the glucose is low and you correct that, the slurred speech and everything, the facial droop, all of those got corrected. You understand? So make sure you check your glucose, and then from there, you still do everything else that you're supposed to be doing. All right. So if low BP, give normal saline per orders. Yes, but in terms of when that patient stepping through the emergency room or to your floor or wherever, if you notice even if the patient is in your, on the inpatient side, and the patient is in bed, the patient is having all of that, the first thing you want to do is make sure you go ahead and get a glucose and see whether or not this patient is hypoglycemic. All right, you want to make sure you get that going. All right. Wait to see if symptoms resolve. No, we're not going to be waiting around. All right. Give aspirin before imaging automatically. For this patient that comes in, what are you anticipating as well? So the patient is having sudden unilateral weakness and slurred speech, and the doctor orders for aspirin. What are you going to be doing? A. Yes, we definitely need A, which is a time last known well. So this patient is having the slurred speech. We anticipate that it's a stroke, and the doctor orders, you know, aspirin because it's a part of their it's a part of the protocol, activation protocol. So they have a stroke, they activated it, and all of the orders just, you know, go through the window. So aspirin risk for bleeding. Aspirin is risk for bleeding. Okay. So, all right, so we do the CT scan. CT scan looks good. There's no bleeding. All right. And you have the patient, but the patient still has a slurred speech, and the patient has unilateral weakness. All right. The patient has aspirin to be given. What are you anticipating? What are you going to be doing? So the doctor says, hey, John, you know, this is the order for the patient. I want to make sure you go ahead and do, okay, so clock factor, question to doc. Oh, of course, question the doc. I would get the CBC, H&H. Okay, all right, you guys getting everything. You guys get everything, you're getting everything. But I was thinking, so the patient has a slurred speech and you have an oral medication, you have an aspirin that you need to give. What you need to do, think safety before I give it. Yes, Mary. What you need to do. So before you give that aspirin, what you need to do for this patient, hold the medication, request for IV. NG tube or change to IV. Okay. But make sure you do your swallow test. Alright. Go ahead and do your check-off list for your swallow eval. Alright. Yes, we know that the patient have a slurred speech, but still go ahead and document, you know, do your swallow evaluation. Yes, Gertrude will do the vitals and all. Alright. But make sure you get your swallow evaluation, and then from there you can decide whether or not this patient is really having problems with swallowing. All right, because sometimes they'll have the slur, but it doesn't mean that they can't swallow. All right, so sometimes they can pass their dysphagia screen. All right, so definitely do your swallow eval, document that, and then from there. All right, with the little water test. All right, so find out the dosage needed. NG tube or change to IV. Allergy check. All right, so all of those are the NG tube or the change to IV. I want you guys to do the swallow. Make sure you document your swallow eval. All right, the swallow eval is very important. Platelet count. Yeah, we're definitely gonna do all of those in the blood work. All right. Not a problem, Nadu Jean. All right. Yeah, that's why I think my little study session here is a little bit different. I want us to interact a little bit. I want to pick your brain a little bit. All right, and then from there, I think we cover a lot more like this. Yes. All right, so always remember your swallow eval. So you see the give aspirin here. Always make sure your patient can swallow first and is not gonna be aspirating when you give this medication. All right, and then from there. So the answer here is A. You want to look at the time last known well, and we say the window for TPA is going to be your 4.5 hours. All right, within that time period, and then from there, get a patient to CT, get your glucose check to make sure this patient is not hypoglycemic, and then from there. All right. Stroke protocol requires time of onset and immediate imaging. Interventions depend on the type and timing. All right. All right. A patient with DVT started on a low molecular weight heparin asks when they can stop leg exercises. What's the best advice? A, avoid all movement. B, continue gentle ambulation as tolerated. C, perform strenuous leg exercises. And D, use leg compression stockings only at night. So this patient that has DVT, the patient is on heparin, and they ask you when they can stop the leg exercises. What's the best advice? I see B, 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 B. Okay. Continue gentle ambulation as tolerated. Definitely. All right. So ambulation is usually encouraged with DVT when anticoagulated. Abrupt immobilization increases thrombosis risk. Avoid prolonged immobility and follow anticoagulation plan. Light exercise. All right. So always look at the words as well in the answers. So strenuous. All right. Use leg compression stockings only at night. Is it only at night or all the time? All right. Continue gentle ambulation as tolerated. That sounds a little bit more, you know. Avoid all movement. Definitely not. All right. You still want this patient to be moving. You want blood circulation. All right. So definitely you will continue gentle ambulation as tolerated. All right, so you have this patient that has DVT. What are you anticipating in terms of signs and symptoms for this patient? Pain, okay, swelling in the legs, pain, redness, clot, nice. Okay, pain, all right, nice. Is this the new NCLEX-style? I doubt it, you know, K. Myers. We're just studying and prepping for NCLEX, all right? No, these are just general questions, NCLEX-style, all right? We're just trying to do general studying here. For the NCLEX, home and sign. Okay, nice, nice. Okay. All right. So what are some risk factors for DVT? What are some risk factors for DVT? Immobility. PE, blood clots, pregnancy. Okay. Heart failure, long flight and rides. Yes. Pregnancy, smoking, obesity. Yes. Nice. You cancers and everything. Nice. Okay. Surgeries, traumas, all of those things. Venous insufficiency. Okay. All right. Nice. All right. And so we say for this patient, thank you guys. I see a few persons who came on earlier still hanging out. Thank you, thank you, thank you. Remember to go ahead and follow. Oh, and for all of the folks who have sent the heart me's, thank you for doing so. All right. Remember to go ahead and claim your points. All right. All right. So for your low molecular weight or for your heparin patients, your patient that is on heparin, what lab values will you be keeping your eye on? Again, deep vein thrombosis pop. Asking what DVT is. All right, your AP. Okay, nice. Your PTT. All right, platelet anti-XA. APTT. All right, nice. So you want to keep an eye on your PTT. All right, factor XA. Nice. All right. So ambulation is usually encouraged with DVT when anticoagulated. Abrupt immobilization increases the thrombosis risk. Avoid prolonged immobility and follow anticoagulation plan. All right. And have protamine sulfate on standby. All right. So what is protamine sulfate? What is that for? Why you want to have it on standby? For your antidote. Nice, nice. Yes. Okay. So a client with hepatic encephalopathy shows asterixis, flapping tremor. What is the priority here? What is the priority? A, evaluate ammonia level, reduce protein intake, as ordered. Give lactulose to reduce ammonia. B, increase dietary protein. C, ignore, it's normal. D, start benzodiazepine. B, because they could have elevated ammonia. Oh, A, you say, okay, yes. Okay, nice. All right. So A. What lab values you'll be keeping an eye on for this patient? Okay, yeah, ammonia, LFTs, bilirubin, okay, lipid, uric, BUN, nice. So your liver enzymes, bilirubin, okay, nice. So keep an eye on your liver enzymes and all right. Increase dietary protein, ignore, start benzos. Why would you be thinking about starting benzos for this patient? Why would benzos be a part of this part of this management? Everyone's welcome here. Welcome. Okay, nice. Your seizure activity, alcohol withdrawal. Okay, so depending, yes. All right, so prophylaxis or as a part of the treatment if the patient is an alcoholic. All right, if they notice behavior changes and agitation due to the excess ammonia. Okay, anxiety. All right, but mostly for your prophylaxis for your seizure. All right, and if they're doing it for alcohol withdrawal. All right. The benzo definitely based on the scenario. All right. Okay. So we say that the answer is A. Asterixis suggests metabolic encephalopathy. Lactulose and ammonia management are indicated. Let's go back to this one. So what are you anticipating in terms of the, is this patient going to be hypoglycemic or hyperglycemic? Hypoglycemia. Okay, yes. So this patient is going to be hypoglycemic. Okay. So remember that the liver stores your glucose as your glycogen and then releases it as needed. Yes, the answer is A. Evaluate ammonia level, reduce protein intake. All right. So this patient is going to be at risk for hypoglycemia because when you have severe hepatitis going on, then you have reduction in that glycogen storage. All right. And then causes the patient to be hypoglycemic. All right. A patient with acute pancreatitis develops hypocalcemia, signs tetany. What is the best action? A, start oral calcium at home. B, monitor electrolytes closely. Notify provider and prepare for IV calcium replacement if ordered. C, encourage calcium-rich foods only. Or D, do nothing. So if a patient with acute pancreatitis developing hypocalcemia, signs, tetany. Okay, what's the best action? We say B. Did we say B because B is longer or B is just the right one? So B, monitor electrolytes closely. Notify provider and prepare for IV calcium replacement if ordered. All right. So acute pancreatitis. What lab enzymes are we going to be monitoring for? We're keeping an eye on. Because it has... hi, Jacinth. Tuesdays and Thursdays, I do the NCLEX study live at 7 p.m. All right. I might come on. I'm still working on additional times during the week. So you can pop in at 7 p.m. All right. I might end up start doing it a little bit more frequent than the 2 days. So just check out at 7 p.m. and see if I am here during the other days because I'm working on that. All right. Okay, so B, lipase and amylase. Yes, definitely want to look at your, oh, sorry, CS time, CST. 7 p.m. CST, Central Standard. Okay. All right, so definitely. All right, let's go back to the same hypo and hyper. Is this patient going to be hypoglycemic or hyperglycemic? Okay. Because you know the glucose, the pancreas regulates your glucose there. All right, so definitely glucagon production is gonna be altered. All right, so eventually the patient is gonna become hypoglycemic. All right, hypocalcemia. All right, so we want to monitor electrolytes closely. Prepare for IV calcium replacement if ordered. All right, encourage calcium rich. Okay. Will you keep this patient NPO or not? Are you gonna feed this patient, seeing that the patient is at risk for hypoglycemia? Would you feed the patient to keep that sugar level up? You'd feed the patient, right, Wing? No, we're not gonna feed this patient. We want to rest this patient pancreas, all right? So, no, we're not gonna feed this patient. Keep this patient NPO, rest the pancreas, and then from there, all right? So this is the one time you're not gonna get Daisy Award. Hypocalcemia and pancreatitis can be symptomatic. Monitor and replace your replace per orders. All right, NPO and give dextrose definitely. A patient with COPD, exacerbation is on supplemental oxygen. Which oxygen flow strategies minimize the CO2 retention risk? A, give high flow oxygen 10 to 15 liters to all COPD patients. B, remove oxygen entirely. C, use titrated low flow oxygen to maintain a target SpO2 of, SpO2, and D, always target SpO2 greater than 98. C. Use titrated low flow oxygen to maintain target SpO2. Okay, nice. What's the target SpO2 you're looking for this patient with COPD? $88, 92%. Nice. Okay, nice. All right. We're not gonna remove oxygen entirely. They need a little, they need a low flow oxygen. If you had a patient that is a COPD and you're supposed to give them, a set concentration of oxygen, would you choose between a nasal cannula? Which one of them would you use? A nasal cannula, face mask, or a Venturi mask? Which one would be the best one to give the best? Okay. Okay. Your Venturi mask. All right. The Venturi mask is going to be the one that you can set to give a specific amount of oxygen. All right. So at least you know that the patient is getting this amount concentration. All right. Norkey. All right. So high flow oxygen definitely is going to be out of it for your COPDs. All right. That is definitely out. Always target SpO2 greater than 98 is out, because you want your sat to be anywhere above 88 and below 92, 88 to 92%. All right. So your COPD patients may retain CO2 with high O2. Titrate to target saturation to balance oxygenation and CO2 retention. 88 to 92% is your target on that. All right. A patient with acute stroke receives TPA. Nursing monitoring priorities include A, start aspirin immediately at full dose. B, only check vital signs every 8 hours. C, allow heavy activity immediately. Or D, frequent neuro checks, monitor for bleeding, blood pressure control, and per protocol. Okay. D. So a patient with acute stroke receives TPA. Nursing monitoring priorities include D, frequent neuro checks, monitoring for bleeding, BP control per protocol. What is TPA? Yes, what is TPA? We tend to hear it all the time, but what is it? Yes, it's a clot buster. Okay.
Plaster.
But the T is for tissue plasminogen activator. All right, just in case that's what she was looking for. Or all right, so it's a clot buster. And who was that? Oh, you don't have a name. You look like a butterfly. It looks like a butterfly. But what is a TPA, you had asked? All right, it's a tissue plasminogen activator. It's a clot buster. All right, so you use it a lot of times with your stroke patient once they're within that window and they meet the criteria. What are some contraindications to having a patient getting TPA? So you have a patient that is supposed to get this TPA. So the patient comes in and the patient is having stroke-like symptoms. We know that the patient has a stroke, all right? And the patient, doctor orders for, okay, your TPA. What are some contraindications to this patient having it? The time frame, recent surgery, nice. Hypertension, hypertensive emergency. All right, 4-hour max after first symptoms. Okay, yes, you give it at that time. Oh, after. Glaucoma. Okay, if the patient has a history of GI bleed. All right. I remember the recent surgery has to be in a specific time period as well. Because if it is 1 month ago they had the surgery, all right, then they are also contraindicated. So always look at the time period. I think it's anything within 3 months. They've had surgery within that 3 months period, then it's contraindicated for them. All right. Because remember, they're so prone to, they're going to be at risk now for bleeding. So you have to make sure that you don't give this medication and then, yeah, you gonna cause additional problems. All right, from there. Alrighty. One last question, because I did say that I was going to finish at what time? Oh, my word. Yes, so the answer is D. You want to do your frequent neuro checks, monitoring for bleeding, blood pressure control per protocol. All right. And why you really want to monitor, you want to keep this patient's blood pressure under control. So this patient has received TPA. The patient is a stroke patient. Why you want to make sure that you're very, you're monitoring this patient's blood pressure closely. Why you want to keep a close eye on this patient's blood pressure who has received TPA. It will cause hypotension, because hypertension can be a risk for hemorrhaging, okay, risk of bleeding, risk of shock. Okay, to see if it's lowered. Okay, yes, even there we want to make sure that if the blood pressure is high, it's lower. But specifically with this patient that has TPA, want to keep a close eye because you don't want the blood pressure to be skyrocketing and then this patient starts having a bleed, a brain bleed. All right, so definitely you want to keep a close eye on that blood pressure to prevent any further problems. All right, because remember, this patient is getting the TPA because there is no brain bleed. All right, there is no brain bleed. So you don't want to be a case where we're not keeping an eye on the blood pressure and then we have given them this TPA and then their blood pressure gets high and then they have TPA on board and causes more problem. All right, so you want to make sure you're keeping that blood pressure low. All right, so you monitor your neuro checks. Initially you do your neuro checks like every 15 minutes for a certain time period. All right, I think it's like 1 hour and then you go to every 30 minutes, 1 to 2 hours every 30 minutes and then every hour for hold on, let me pull it up and see something here. So TPA neuro checks, let's see what it is. Where's the internet? Okay, so what is it? TPA neuro checks. So always keep an eye. A lot of times these patients will be like a one-on-one. So if you have other patients with you and they're complicated, then definitely you're gonna have to, let your provider know, not your provider, but your charge nurse know that this is what is going on. And a lot of times they will take your other assignment and assign it to someone else, and then you are focusing on that patient. All right, because you want to make sure you're not causing any form of brain bleed with that patient. All right, so you want to go ahead and do so say you get your baseline NIH score, your NIH score, you do your vital signs, you're also doing your neuro checks. All right, you always do your neuro checks. And as a part of that, you're always opening the eyes. Yes, the patient might be sleeping. Open the eyes and look at the pupil. All right, shine the light in the patient's eye. Look at the pupil and see how it's responding. All right, so you look at your you do your neuro checks, level of consciousness, speech, pupils. You want to also look at your lab values and everything. And then you do neuro checks every 15 minutes during the infusion. All right, and as I say, it's very, very important for you to keep an eye on that blood pressure. So just like how you're monitoring the neuro, all right, just like how you're monitoring this patient's neuro status, is the same way you're gonna be monitoring this blood pressure as well, every 15 minutes, and try to look out for the goal that they're wanting on this blood pressure. All right, so you do every 15 minutes, yes, for every 2 hours. For the first 2 hours after infusion, you're gonna be doing your 15 minutes neuro check as well as you do your blood pressure check as well. Every 30 minutes for the next 6 hours, and then every hour until 24 hours. So make sure you're charting from start to finish. All right. No anticoagulants or antiplatelets for 24 hours after the TPA. You're going to watch for your bleeding, the nose, the gums, the urine, the IV site. If the patient has in a nasal cannula, make sure you're watching that site, because sometimes they tend to become a little bit dry. The mucous membrane become a little bit dry because of the oxygen. So the patient is going to be at risk for bleeding there. So keep an eye on your the patient's nose, all right? And then they're going to repeat the CT scanning 24 hours after starting. So that's why I say usually it's 1-to-1, all right, because you have a lot of monitoring to do with these patients. And then from there, red flags that you're looking for during your neuro checks is if they're having sudden decrease in their level of consciousness, if they've developed any new weakness, numbness, speech changes, severe headache, vomiting, especially when they talk about the headache. Yes, ask the patient, are you having any pain? Things like that. All right, if the patient can't answer, using the pain score that we talk about, the 0 to 10, go ahead and try other pain scores scale to check to see if this patient is hearing you, understanding, so you can know whether or not this patient is having pain. All right. And as I say, you always look at the pupil Look at how it's reacting. All right. Yes, hemorrhagic strokes, they tend to have the worst headache of their life. All right. So you want to make sure you're listening out for that if the patient is able to talk. All right. But make sure you're keeping an eye on those pupils. Dropping the blood pressure or sudden hypertension. All right. And then from there. All right. So make sure that you read up on your TPA and what you need to do during those time period. All right, I did say one last question. So we say that the answer is after thrombolytics, close neuro and bleeding monitoring plus BP management are critical. Antiplatelets are held per protocol. All right. And then from there, sometimes some providers will go ahead and order, depending on what's going on. Some persons will go ahead and order like anti-seizure medication, things like those. I want to be a CRNA, but I'm from the Caribbean. What do I do? Where are you now, though? Are you still in the Caribbean? Yeah, so just make sure you read up on all of those things and then from there. All right. Still in the Caribbean, but gonna write CSEC next year. Oh, you have a long way to go. Continue following my page. Go on to YT, subscribe to my page. My live streams are over there. All my live streams are over there. So definitely go over there and hang out and watch some of the videos regarding the different systems that we've covered here on TikTok so far. All right, it's ThinkNursing, one word. Subscribe. It's the same thing as the handle here on TikTok. So go over there and subscribe and watch the videos that I post. In the meantime, you say you want to be a CRNA, you're about to write your CSEC, you start your nursing program, and then I would suggest, start your nursing program, get your BSN, and then from there, depending on what's happening at the time when you are a nurse, then you can decide to go ahead and do the CRNA. So if you're in the States here, usually our program is equivalent to the US or BSN. So then you'll definitely need to get into acute setting. So if it's ICU, emergency room, but I would say if you can get into ICU, then definitely start working in ICU. And then from there, you will be able to apply and get for your CRNA. All right, can do your NP and everything. All right. What was the question again? Oh, she was asking, or I don't know, G was asking about wanting to do CRNA, but he or she is from the Caribbean. So I was just kind of telling he or she about the process. G, are you, he or she. All right, so that's just it. But yeah, it is 10 o'clock where I'm at. All right, it's 10 o'clock. I'm gonna do 3 charts and then go to my bed. So, but it was nice having you guys on the live tonight. All right, as I say, I'm trying to work on some additional questions. But as I say, the questions we kind of go through it in detail. So I think we're covering a lot with the question, and that's the most important thing. All right. I'm trying to see if I can subscribe to or get. I have an exam on, so it will. Okay, nice, Julia. I'm trying to see if I can get the U World, but U World is so expensive. But anyways, I'm gonna try and invest in it, and then from there. But I don't want to get it and then nobody shows up for the live. That way. Yeah. So that's it. So I'm still getting questions from the internet, and we just kind of dissect it and answer different questions that I might pull, pick your brain with, and then from there. But I'll eventually do that, try to do like a boot camp. And yes, it is. I was looking on the prices and I was like, ooh, yeah. So that's just it. And I know somebody talk about the Kahoot. Kahoot is a lot of time. It takes a lot of time because you have to go ahead and put in the questions, the answer. Yeah, I don't think we will cover enough as much as I'd want to cover. Sorry. And that's just it for now. Sorry. I think this fan is kind of causing my throat to go. So I am planning on continuing with, you know, the questions and oh my word. Sorry. Yeah, I'm planning on doing the questions as how we're doing it now. And then from there. All right, but if you have a system or if you have a topic that you want me to prepare questions for, feel free to go ahead and inbox me. All right, and then from there, we'll try to cover more questions. All right, but for now, on Tuesdays and Thursdays, I've dedicated to you guys, and just come out and show your support. All right, and then from there, okay, I'll try to work on other days and time. All right, and thank you for the follow, guys. If I haven't said it as yet, I really do appreciate it. The hearts, the gifts, all of those, I appreciate it. All right, so and congratulations to all the persons who have done their NCLEX already, their exam, or in the process of sitting, you know. Okay, nice. L, okay, no problem. You're gonna enjoy it. It's a nice career. All right. Yeah, so definitely come over and hang out and just watch some of the content. Definitely go onto YouTube as well. Go onto YouTube and follow my page. Subscribe to my page over there. I do post long form contents on YouTube, and all the live streams are posted over there as well. All right. So until then, I'm gonna say enjoy your night. All right, and then from there, we'll see. Oh, the handle is ThinkNursing. It's the same name as the one on TikTok here. I thought this one was called. So it's ThinkNursing, one word. So just go ahead. Go ahead, pin it. Yeah. And then from there. All right, so ThinkNursing. Yeah. I guess I lose my voice right in time. All right, and then from there. All right, then, well, enjoy your night. All right, and stay safe. You're welcome. No problem. No problem.